I have to read case or you will read it? You read it case, I should read. Should I read the case or you will read? So, a 76-year-old male with history of typical angina, with history of CABG 4 years back for triple vessel disease, now has occluded SVG and RCA graft, but patent SVG to LX and Lima to LAD. Stress radionuclear imaging had revealed mild reversible ischemic territory of circumflex. His ejection fraction is 40% and is class 2 angina along with class 2 dyspnea on glycemic trinitrate 6.4 milligram twice daily, apart from DAPT and high dose of statins. He is already on metoprolol 100 milligram, ARNI and SGLT2 inhibitor. His resting heart rate is 78 beats per minute, blood pressure 106/70. He has occasional VPCs on ECG. So here is the role of Dr. Somu. His coronary angiogram revealed slow flow in native right coronary artery with borderline troponins, but normal CPKMB. The preferred modality of next line of anti-anginal would be. Over to Somu.
Thank you, sir. Respected chairpersons, moderators, Kamal Sharma ji, thanks for having me here. The bouts are always about telling that what is good for you and what is bad for the others. So I'll start for what is good for the patient, and then I will go on to what is bad for the. So for patient who has a resistant angina, what we use normally is beta blocker, calcium channel blockers, nitrates. And then if they don't work, the next step is to go on to the other drugs that we are going to discuss. And then the other ways, we are not going to be going anywhere further. So this is a comparative chart of the treatments for stable angina. And if you see, this gives you an overview. And for drug with metabolic effects, which include ranolazine, trimetazine, ivabradine, and nicorandil, these are the major four. What you see is, the most important is, all are good. It has everything there. But reduced prevention of MI, improvement in survival is only nicorandil. So I'm speaking for my opponent. But for the patient, what is important? So it is very important to go to the patient and then see. So here we'll see of mechanism of action, how does it work, what are the current guidelines, the major trials and comparison. So which of the following agent can be monitored for therapeutic efficacy? So if I give any of the three other drugs, which agent of the three, trimetazidine, ranolazine or nicorandil, you can monitor the efficacy? It's only ivabradine, because you can monitor the rate, say that this is effective. There is an endpoint for giving ivabradine that you want to get the heart rate to less than 70. So it blocks the IF channel and thereby increases the it causes some bradycardia, increases the diastolic time, improves the coronary blood flow both at rest and during exercise. And that's the mechanism that is very important. It favors the collateralization and may prevent endothelial dysfunction. And that is not what I am saying. These are the studies that have quoted this over a period of time. So what does the current guidelines say? So let us see which second line anti-anginal medication can be started based on clinical examination with titration according to clinical examination easily, and can be combined with most medications. So if you, of these, the answer would be ivabradine, because you cannot combine nicorandil with a long-acting nitrate because the incidence is nearly 30% of headaches and withdrawal. Ranolazine can prolong the QT, and trimetazine, I am not even talking about that. The most important thing is it's a safe drug, and very importantly, you can guide based on clinical examination. So let us see what is approved and not approved. The FDA has approved ivabradine in heart failure with ejection fraction less than 35% and with an average rate of more than 70 beats per minute in spite of good beta blocker. And this, our patient, though has an ejection fraction of 40%, has a heart rate more than 70%. The other indications in are by the European Medical Association, or they say that it can be given in angina also, where the heartbeats are more than 70 per minute. So FDA is limited to heart failure, but European Association says that it can be given for angina also as a second line medication. So the current guidelines have approved as a class 2A indication in heart failure with patients who have a heart rate of more than 70 in spite of beta blocker, while ivabradine should be considered as a second line drug to reduce the angina frequency if it is not being tolerated by beta blockers, calcium channel blockers, or long acting nitrates. So that is a class 2A. Rest are all class 2B, right? So these are add-on drugs. So if this is by the ESC guidelines, so if you see standard therapy, what they say, beta blockers, calcium channel blockers, and as a second line drug, ivabradine or nicorandil or ranolazine. But with high heart rates, it's ivabradine that is recommended. With LV dysfunction and heart failure, ivabradine is the first choice after beta blockers. And with low blood pressure, again, if it is not tolerated by beta blockers are not tolerated and other drugs are not tolerated, ivabradine is again the choice. So in all of them, ivabradine takes place as one of the choice if the first line drug fails. So how do you start ivabradine? It's started at a dose of 5 milligram twice daily. However, in patients who have existing bradycardia to a certain extent, or otherwise, you can start with 2.5 milligram twice daily and then assess 2 to 4 weeks and then increase the dose to maximum, if possible, to 7.5 BD, and if still the heart rate is not controlled, go to 10 milligram BD. So combinations, what are the combinations that are not recommended? It's beta blocker plus diltiazem plus ivabradine. This 3 is not recommended, but then otherwise everything else is recommended. So you don't combine diltiazem plus ivabradine because of increased side effects and change in the pharmacokinetics also. So let us go on the trials, which is the second anginal line drug, which is the most studied both in stable angina and heart failure. And the answer would be ivabradine, because others are more in stable angina rather than heart failure. So both the drugs, it's more important that ivabradine is again there. So in this patient, we had heart failure, dyspnea, plus angina, and therefore this drug goes. So what are the trials supporting? So you have a beautiful trial which was there in patients with ejection fraction less than 40%. Though it did not decrease the mortality, it decreased the events, especially in heart rates more than 70. SHIFT trial again in patients with heart failure, it was basically designed for heart failure, while Signify was designed for angina, wherein it did not give a benefit in a patient who had a ejection heart rate of less than 70. So here is the trial, that was the first trial, that is the initiative. It was given as before as 2005, and these patients were said that it is a good alternative to atenolol. That was the first trial that came, and then adding on to a beta blocker, it said that it increases the time to angina, it increases the ST depression, so it decreases the time to ST depression and also the time to initiating the angina. The beautiful study was the study that brought ivabradine into picture, and that was in terms of heart failure, and this said that patients who have a heart rate of more than 70, the patient would benefit significantly more, and that too to the tune of 73% reduction in rate of hospitalization and 59% reduction in the rate of coronary revascularization. The SHIFT trial, again in Lancet, it said that there is an improvement in the clinical outcomes of heart failure, especially again with a rate of more than 70. However, this trial, that is the Signify trial, did not show any benefit, was a negative trial or not an inferior trial. But the other trial, most of them like associate trial, then the patient additions trial, all suggested some benefit of ivabradine, and multi-center randomized meta-analysis also showed that benefit to be persistent both in heart failure, especially with a heart rate of more than 70. So there is one of the study which shows that ivabradine also increases myocardial perfusion. Overall, results of trials in chronic stable angina and heart failure suggest that quality of life definitely is improved, and the clinical efficacy as judged by physicians is very good. That's more important. So physicians are comfortable in giving ivabradine and saying that I can monitor the heart rate, and there is a significant betterment in these patients. Also, the safety is good, efficacy is good, and it is easily available, and it is considered to increase the quality of life better. So let us see with the other line medication, which anti-anginal medication has the least side effect, ivabradine of all the thing. And when you compare with other drugs, as you see, it is the best tolerated. Again, it doesn't change the blood pressure much as compared to nicorandil, which is the most studied and which has the most evidence in angina. Regarding the therapeutic targets, mechanism of action, we all know, but it's very important. Ivabradine has only side effects if related to flashing and causing bradycardia. Rather than that, no hypotension, no decrease in the chronotropy, and no QT prolongation most of the time. So standard therapy limitations are there, especially in beta blockers, especially if the blood pressure is low. If your blood pressure is low, the next step that you go is ivabradine rather than ranolazine or corandil if you have to give it as an anti-anginal or an anti-failure medication. So what about nicorandil? Nicorandil, the trial says it is too good to be true for various purposes. What about ranolazine? Most of them say that it is good, but it is only limited effect with evidence of long QT. And there are negative trials also. The cost is remaining the same. So what is the overall perspective? You can have angina for various reasons: vasospastic, obstructant related, and microvascular. So in this, what has been mentioned is, if you have an occlusive CAD, give ivabradine rather than others. If you have coronary spasm, it is nicorandil or long-acting nitrates. If you have microcirculation related issues, then there it is again nicorandil. And if you have microvascular dysfunction, then ranolazine might be given. So for our patient, he had obstructive CAD, and therefore I would suggest that a patient who has an obstructive CAD, exertional angina with mild heart failure, ivabradine gives you the best choice as compared, whereas if it was variable threshold angina or microvascular, the others would have been better as compared to ivabradine. For our patient, therefore, ivabradine I strongly recommend.
Dr. Somu has already, we are not fighting, but just we have to put our stand here. So as we look at this case, he is a male of 76 years. Of course, diabetes status is unknown, LV dysfunction is there, and he has implanted a graft over RCA, but only slow flow in RCA, no significant coronary lesion into the RCA. Viability study, mild ischemia, something like gray zone, and top eyes bottle, and that can occur in LV dysfunction also. So, and of course, he has got occasional VPC on ECG. That is also one thing that is in favor of me. So we know that whenever the first line of drugs, he has given all the first line of drugs, and that first line of drugs, till the patient is symptomatic. So we have got options like this. So with available option, we have to see the trimetazidine, nicorandil, ivabradine, and ranolazine. I think trimetazidine not here today. And of course, Jayesh bhai is behind me with nicorandil also. So we know that second line therapy, here this is a metabolic modulator kind of drug. So this is the segment which remains, because nicorandil and nitroglycerin is almost same kind of action. So advantage of ranolazine has got both the things. Advantage of trimetazidine as well as the late inward sodium entry, that is added advantage of ranolazine. And ranolazine already been FDA approved since last 2006, while nicorandil has been not approved for this indication. So of course it has got a metabolism, fatty acid metabolism, glucose metabolism that is favorable with trimetazidine, ranolazine both, But some of the things with ranolazine is the lead sodium. So influx of the sodium and calcium overload is prevented. So diastolic dysfunction has been improved and anginal episode has been lower. When we see the study wise, so this molecule is given in a dose of 500 milligram BID increased to 1000 milligram BID, and it has been studied in stable coronary artery disease like MARISA, CARISA, ERICA. And of course, in ACS situation, the Merlin TIMI 36 has been studied. Mind well, the class 2 drug, second line therapy has been only they have got a symptomatic benefit, mortality benefit is not there. So all these have shown that reduced sublingual and exercise capacity, feeling well, and all these things. And Merlin TIMI 36 trial has been done, and that has shown one added advantage of ranolazine, that is antiarrhythmic effect. So reduces the VPC burden, and of course the continuous 8 VPC were lower. So that was added advantage in such kind of patient wherever there is a ventricular ectopics. And nowadays even the SOMU also agrees that ranolazine has been given for the patient having a recurrent ventricular tachycardia or patient having more VPC burden. We are giving the ranolazine for this regard. And of course one thing, when we give the ranolazine, we have to see the QT prolongation. So when we go to the higher doses, I think more than 1000, and probably we have to see for the drug-to-drug interaction that I am going to discuss. So that causes the more QT prolongation, and that is hazardous. But mind well, most of the studies have not shown the torsades de pointes. So malignant ventricular tachycardia has been not only QT prolongation is there with a higher doses of ranolazine. And of course we have to see T-wave notching can also be noticed in ranolazine group. So long QT syndrome also, even sometimes the treatment part also long QT3, there is also drugs to be given is the ranolazine. Another advantage of these are some of the studies has been done, and it has shown that reduces the principally Merlin trial and other studies has shown that reduce even ICD implanted patient whenever the frequent episode of VT when we give the ranolazine reduces the delivery of the shock. And of course one thing is that improves the atrial fibrillation, conversion to the sinus rhythm, and new episode of atrial fibrillation. Even these are the 2 or 3 studies available in post-CABG patient, immediate post-CABG, pre-surgical patient, even the valvular patient, even with amiodarone and ranolazine combination. Of course, we have to see for the QT interval, but it has shown that reduced episode of atrial fibrillation and conversion to atrial fibrillation to sinus rhythm and maintenance even with a post-surgical patient has been noted with ranolazine. And all this, these are some of the data meta-analysis. All this meta-analysis has shown that reduces the recurrent episode of angina, quality of life. Another advantage of ranolazine diabetic group is a reduction in HbA1c. But drug-to-drug interaction, I am going to discuss what will happen in diabetic patient. So of course improve the glycemic control in diabetic patient, and of course reduces the pill episode of angina also. Another thing is side effect. Of course, side effect profile is not in much favor of ranolazine. Some of the symptoms like dizziness, giddiness, constipation, nausea, blurring of vision, that has been also evaporated. Same with the ranolazine can also occur. We have to see, important cheese is we have to see that drug-to-drug interaction. So whenever we give the diltiazem, verapamil, macrolide antibiotic, then we have to reduce the dose of ranolazine. And metformin, when we give high dose of ranolazine, we have to see to it metformin dose should not go beyond 1700 milligram. And of course, rifampicin, phenytoin, we have to reduce the dose of this molecule. So we have to keep in mind grapefruit juice and all. So drug-to-drug interaction, so narrow therapeutic window, so side effect profile and drug doses we have to see. And whenever this is the combination, it's of course class 2 drug. So most of the combination are with not with the yellow, but it's the blue line. So these are the possible combination that we have to see, and ranolazine can be easily combined with most of the molecule. Now the SOMU has shown is the class 2022 ESC guidelines. So 2023 AHA guideline has shown the ranolazine advantages over others. So in patient with chronic coronary disease, ranolazine is recommended in patient who remain symptomatic despite of first line drug like beta blocker, calcium blocker, long-acting nitrate. While see that the ivabradine is a class 3 in patient with LV dysfunction, without LV dysfunction. So in patient with CCD and normal LV function, the addition of ivabradine to standard anti-anginal therapy is potentially harmful. So patient with normal ejection fraction, we have to be careful. And even the ESC 2024 has recommended little age over nicorandil and trimetazidine. It is 2AB, while trimetazidine and ivabradine is a class 2AB also, but with LV dysfunction. While nicorandil and trimetazidine is 2B recommendation. So nicorandil and trimetazidine may be considered. So nowadays they are behind ranolazine when fight between the second line therapy is going on. And of course, we have to see the class 3 recommendation. Ivabradine is not recommended with higher ejection fraction and contraindication with other calcium channel blocker drugs, and that we have to be very careful. So to conclude this discussion, of course, it's a drug that is to be given in such kind of cases where after giving the all first kind of line therapy, and patient has got a VPC burden, post CABG, diabetic status I don't know, and it has got a, of course, some kind of coronary obstruction with microvascular dysfunction, and probably this is a drug which has got a potential to arrhythmias also. So ranolazine can be a good choice in these cases with reasonable doses, starting with 500 milligram, increase to 750 or 1000 milligram BID. Thank you so much.
Last speaker of the day, Dr. Jayesh Raval. Nicorandil, Minoca, Inoca.
Respected chairpersons and friends, I'm supposed to talk about a case which is very peculiar, and nobody has drawn your attention to that part, that this patient has RCA graft occluded, some trickle flow is there in RCA, and the demonstrable ischemia is documented in circumflex territory. By circumflex territory documented ischemia, and still circumflex graft is working. So you have a non-obstructive territory which is ischemic, and you have a occluded graft, totally necrotic tissue in that area, and that is not producing any symptoms of angina. So when I'm talking about angina, angina is distant angina beyond RCA territory, and the graft to circumflex is working. So it's a peculiar scenario where inoca or anoca is diagnosed, and I'm just going to tell you the details of all these things in a nutshell. You know, angina or myocardial infarction in non-obstructive coronary artery disease. By non-obstructive coronary artery disease, I mean to say less than 50% stenosis in that particular area. And what happens commonly when we go out to the relatives and say that you don't have any obstructive lesion, your coronaries are normal, it's a joyous reaction from family. So it's a good news to the family and patient, but that no CABG is required, no stent is required, redo CABG in this case is not out of question. So only drugs, and choice is yours. The two choices you have already listened to, and those two choices are not my cup of tea. Why? That we'll discuss on further. But 40% of all coronaries have some non-obstructive lesion. Coronary angiogram taken in any center of the world, 30 to 40% are non-obstructive, and some 50% of women are presented with anoca or inoca. So anoca, inoca, is it a happy news? No, it's not a happy news, because risks are almost same. If I have coronary artery disease having triple vessel disease, and if I have minor lesions and ischemia in all three coronaries, I don't need stent, I don't need CABG, but at the same time my risk remains same. Tenfold increase in heart failure, preserved ejection fraction, stroke, microvascular dysfunction, Inoka multivessel disease is similar to that of patients with single vessel obstructive CAD and ischemic complications. So risk is not less. So it's not a happy news for the family. And there are three typical scenario. First and foremost is we all studied together princemental angina, epicardial coronary arteries, vasospastic coronary artery disease, and then there is a microvascular disease, small vessels producing angina. And you can have a vasospastic element over and above microvascular disease where nitric oxide is deficient. So these patients, management to date is no standard evidence based medicine, and that's why everybody will go on talking their own preferred molecule, but in nutshell it's the underlying mechanism what we perceive. And in this scenario I would say that this is a microvascular angina in circumflex territory which is causing problem, and there probably renolazine or there probably ivabradine has a little less role as compared to nicorandil. Dr. Soumya has already discussed about, documented clinical relevance or clinical identification of drug efficacy. But we have used aspirin, we have used clopidogrel, we have used sacubitril valsartan, but immediate clinical scenario may not be evident enough. So using a drug doesn't mean that all the time you have a clinical relevance, clinical monitoring. Of course, clinical monitoring is good, but that does not mean that it's an essential part of my therapy. The three types of angina mechanisms: first is microvascular angina, second is microvascular spasm, and third is epicardial vasospasm. All three are affected, all three are suppressed by only two kind of molecules. One is calcium channel blocker. Here nobody is talking about calcium channel blocker, so I am not touching that part. Apart from other molecules, only nicorandil stands. Nicorandil is the only drug which has impact on all three mechanisms of microvascular angina. So nicorandil coronary microvascular vasodilatory effect will be there, and that is balanced one. So first line therapy here will be verapamil, second line therapy will be nicorandil or longer acting nitrates producing vasodilatation, and if at all patient is having arrhythmia, then ICD. Is there a role of nicorandil in this case? Nicorandil mechanism and description I will just keep over because most of us know all these things. But then my point is to tell you the evidence, because out of all three molecules which are being discussed in this session, the first and foremost nicorandil has the maximum volume of evidence. It has come in 2023 ACCH guidelines. Of course, it is third line therapy along with renolazine, but the table of content which has been documented from that 2023 ACCH guideline, the nicorandil is one step ahead of renolazine. There was in 2021 one classical international study group recommendation, and in that recommendation also, they discussed about nicorandil as the third option beyond beta blocker and calcium channel blockers. You have scientific publication right from 1981 to 2023, and in 2002 there was a mammoth trial of Iona. I'll discuss that later on. You have 6 editorial up till now. You have 27 meta-analysis, and all these are favoring nicorandil. Then why not to use nicorandil in my case? Nicorandil in 2023 was discussed as Delphi consensus statement. And these consensus statements are usually like, post-election exit poll. Sometimes they are right, sometimes they are not right. But But these consensus statements do matter because it takes experts' opinion into it. And very important aspect was that this Delphi consensus dealt with number of questions. The first question was whether vasodilatory drugs are less utilized or not. Of course, yes. In such kind of scenario, people are not using long-acting nitrates, people are not using nicorandil. Then whether Inoca requires our nicorandil, yes, 91% of people will say yes. Beta blocker and nicorandil was the first choice for 54% of clinicians, and almost everybody agreed if you have LV dysfunction. In our case, LV dysfunction is present. So if you have LV dysfunction and chronic disease, chronic coronary artery diffuse disease, then 100% agreement in Delphi consensus statement that shows that nicorandil can be used. Nicorandil will work in microvascular dysfunction as well as vasospastic angina. Almost 50% of people agree to that. And of course, heart failure, preload, afterload reduction is also important phenomena. And what is the place in therapy for nicorandil injection? I would say that most of our we cardiologists use it in cath lab, either prior to or after that, and that has a special relation with sluggish flow. Post sluggish flow or post no reflow phenomena, we would be tempted to use oral nicorandil in the follow-up, probably next 3 to 6 months. So these are the scenario where we use chronic slow flow. Of course, there are some legal ethnicity traits also. Small coronary artery disease, type 2 disease of diabetes, polyvascular disease. And in last year, Indian Heart Journal has also published one kind of exit poll scenario. And in that also I would jump into, because the time doesn't permit, but I would just jump into the consensus statement where nicorandil got 120 marks. Nicorandil with dual mechanism of action is effective in angina with normal coronary artery disease. There is crucial role here. Here one poster presentation from CSI conference, and that again shows that IV nicorandil therapy is to be used in TIMI grade 0 to TIMI grade 2 flow. And one more scientific study from China, 2022, that also showed very clear evidence. I would go to 2002 Iona study, 5,000 patients, mammoth study. And this 2002 study reminds me of Dr. Hiromu's lecture. He showed you Karthik Iron's photograph, but that doesn't mean that the older actors are worthless. Similarly, nicorandil, the mammoth documentation came in 2002. After that, we had renolazine. After that, we had ivabradine. So newer molecules are good, but that doesn't mean that older people are to be thrown out. And so nicorandil and Iona study documentation is perfectly all right for me. And then why not beta blocker step up dose in this kind of case? That is also my question. Thank you very much.
Sir, over to you. Comments?
Hello. Sir, my question is, if patient is having chronic stable angina, normal angiogram without any slow flow, normal heart rate and normal heart function, then how to distinguish whether patient is having microvascular angina, endothelial dysfunction, and what should be the first line of anti-anginal drug?
In fact, microvascular testing is available on cath lab, and many a times we resort to, many a times we don't resort to. So the documentation of microvascular dysfunction or stress-induced ischemia with normal coronaries, they are to be documented, of course, before starting any good medication. But the cost therapy, cost of the new investigations hinders us for documenting them.
What should be the first line of anti-anginal drug?
I would still stick on to my recommendation of nicorandil, and Then second line will be longer acting nitrates. I would say one important thing, ranolazine 5% constipation rate, and every clinician has seen that constipation with ranolazine. And you know, constipation is detrimental in acute coronary syndromes. Please. The same thing is evaporating. Evaporating can cause eye problems. Those are very detrimental and irreversible eye problems. So I should not break the other points, but my choice is nicorandil.
Your comment, sir?
Important to know the cause of angina, because there may be many other contributing factors to it, and then focus it on. There was one slide which was nicely shown whether it is obstructive disease or it is a slow flow, it is a endothelial dysfunction, or it is somewhere the problem in microvascular. So it's actually hard to say if the patient has normal angiogram, but if he still is having that typical anginal pain, maybe as sir has rightly said that you can get some challenge test, acetylcholine challenge and all are difficult to do, but I believe that can be done to look the microvascular dysfunction. And for this particular case scenario, I think this is a 76-year-old gentleman, so it's a quite geriatric population here. Rather than to add on, if we can try to just increase the metoprolol dose further, because there is still a chance to go up with that, and to avoid polypill, more drugs with this old age can cause more problems. So I think that's the only thing. Thank you.
Dr. Somo, where atenolol's role today in the case shown to you?
All is forgotten most of the times.
That too by retrospective analysis,
Yes.
meta-analysis.
And the funny
The
part
two
is
bigger point is meta-analysis and retrospective analysis.
Any question, comment from the audience?
Ivabrigadine is also having a, I will share with you as a general physician, his off-label use is ongoing in ICUs where we have severe tachycardia, and we are not able to add the beta blocker because of the worry of the hypotension.
Yeah,
So in
it's-
that setting, we are using it for a shorter periods only.
a very nice drug.
Yes.
Doesn't have impact on blood pressure, but at the same time, if long-term use is there, I fear of eye complications.
the problem, I think, with all these anti-anginal drugs is long term they have to be taken. It's costly, and what happens is with polypharmacy you choose so many drugs together, the cost increases tremendously, and they end up not taking the basic drugs many a times. So they will stop some of the drugs. Aaj aa lidi, pehle nahi lidi, aa karine. So it's always good to stick to the basics. If not, then try to revascularize if possible. That is the best thing.
Oh yes, but in this case, revascularization is
Yeah, and then if not, then they have to be counseled better rather than say that you take this drug. If it doesn't happen, let them have stable angina.
And the same thing is nicorandil, nicorandil has multiple formulations and temperature control, hygroscopic nature of the molecule. So you have to stick to one brand in the era of this
Jayesh bhai,
generic thing.
I have seen lot of atrial fibrillation in old patients who are taking ivabriline. In ICU
Can
patients.
precipitate, it can precipitate.
What books mention is about 6 to 8%, but in real sense, personally, this may be my, maybe
it's my
patients may be
observation
having.
also.
But a lot of times I also see patients of atrial fibrillation started ivabriline. At least that should not happen. That should not happen. A lot of patients get ivabriline for AF with fast VR. That should not happen. And